Welcome to the Marco Town Hall. We would like to start by acknowledging the land on which we are gathering today here in Toronto. This land has been and continues to be the home and traditional territories of the Mississaugas of the New Credit, the Huron-Wendat, and the Haudenosaunee. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. As we think through relationships, it is critical that we recognize Canada's settler colonial history and present, our own positions on this land, and the need to strive to make right with all of our relations.
Thank you, Michelle, for the land acknowledgement. I will proceed with the introduction. The public health emergency due to COVID-19 pandemic has dramatically changed the delivery of healthcare and social services and the socioeconomic conditions we live in. For people experiencing marginalization, these effects have been associated with decreases in income, loss of community connections, exposure to unstable home environments, increased risks related to substance use withdrawal and overdose, and exacerbation of mental health concerns. The Marginalization and COVID-19 Marco study is a large study that evaluated Toronto-based programs and innovations aimed to support people experiencing marginalization during the pandemic. We define marginalization as the condition produced by complex and overlapping factors like economic systems, racism and colonialism, governmental policies, and others, which limit the ability of individuals to maximize their health and well-being. Marco is community-centered. We created a steering committee, which includes both academic and community-based investigators, and a community committee with representatives from 11 diverse community agencies. We worked with our steering and community committees to select the programs for evaluation. We established an evaluation team for each program consisting of 2 or more leads, of whom at least one was a community investigator. Each evaluation also hired people with lived experience as peer researchers. This afternoon, you'll hear from each evaluation team about their work and recommendations.
Chili reducing.
It's not, I'm doing.
Oh, sorry, recommendations for moving forward. Please type any questions you have during the presentations into the Q&A function. We will have time for Q&A after all the Marco teams have presented. I will now turn it over to the first Marco presentation. Thank you and enjoy.
Hello, everyone. My name is Priya Shastri, and I am joined here today by my co-lead, Alexei Kubovich, and we are presenting on behalf of the Marco VAW research team. So at the beginning of the pandemic and currently, there's a growing body of evidence showing an increase in violence against women. And as a result, our project looked at building a shared understanding of challenges and strengths in Toronto's response to violence against women during the pandemic and developing actionable recommendations. Questions we explored were how VAW organizations adapted their organizational practices, how these adaptations are meeting the needs of survivors, and how have contextual factors influenced these adaptations and service delivery during the pandemic. In terms of data collection, we developed a conceptual framework with a research team, VAW organizational reps, and an advisory. We collected 127 VAW staff surveys. We conducted a focus group with the Toronto Region VAWCC. We conducted 18 VAW staff interviews and 10 client or survivor interviews. And throughout this process, we really focused on having integrated knowledge translation. So taking our findings back and checking it with the VAW sector and incorporating the feedback into our next steps. And so now I'm going to invite Alexa to take us into results.
Thanks, Priya. So we had diverse participation across the VAW system of services, including staff who worked at generalist and community-specific organizations and survivors who access both types of organizations. Service types included non-residential services and residential services, and staff worked on and survivors accessed a diverse array of VAW programs, including mental health crisis and support, In terms of our research questions, the first was, how have VAW organizations adapted? We found that most VAW organizations created virtual programming during the pandemic, and staff found that this was one of the greatest opportunities of the pandemic, including increased learning capacity around using technology. While both residential and non-residential services made program adaptations, residential leaders tended to report more dramatic program overhauls, including needing to use hotels, for instance, for quarantining clients before entering shelter, and implementing infection prevention and control protocols. Non-residential leaders, on the other hand, indicated dramatic increases in their VAW caseloads and case severity, and the need to expand their VAW workforce. For instance, one frontline shelter worker described to us, we had to move all our clients to a hotel setting. We had to facilitate this move as smoothly as possible. And then we had to create an office in the hotel, so we were close to the clients. We ran our program from our hotel, which was unfamiliar. There were so many things to adjust to making sure clients had all their needs met. On the other hand, a non-residential service leader described, our waitlist went from 2-3 weeks to now closer to 6 months, like 200 names. Before the pandemic, our agency was the size of 22. Now our agency is the size of 32. And most of those are frontline resources, but we're stuck with a very hefty waitlist. But we can't farm content out and have someone share our load because we're the only one in our community, really emphasizing the additional challenges experienced by community-specific organizations. Regarding the contextual factors that influence VAW service adaptations, the mental health of both frontline and leadership VAW staff were deeply impacted by the pandemic. The majority of staff reported work was more distressing, and they showed significant symptoms of anxiety, depression, and vicarious trauma. Frontline staff reported that flexible working hours and pandemic pay were some of the most helpful supports they received, while organizational cultures of teamwork and resourcefulness facilitated staff's resilience. Coordinating intra and intersectoral work, including with shelter, housing, legal, counseling, and healthcare, continued to be a major challenge that was exacerbated by the pandemic. Many organizations also received insufficient funding for the adaptations they had to make, and especially to address their rising caseloads and case complexity. Flexible funding during the pandemic was a major asset for VAW organizations that received it. In terms of our final research question of how well VAW services are meeting the needs of survivors, we found that virtual service delivery brought many challenges. Survivors described feeling like they were getting less out of programming, making less meaningful connections, and unsure of what was available to them. These challenges were exacerbated for those experiencing intersecting forms of marginalization, like those living with disabilities, those who were newcomers, and those caring for young children on their own. There were, however, newfound benefits of virtual services, including a wider range of supports available to survivors without needing to commute and greater anonymity. In many cases, we heard of a structural context of inadequate funding, resources, and public health support in the face of provincial mandates, which led in some cases to further trauma for survivors when accessing services. For instance, infection prevention and control protocols were sometimes experienced by survivors as victimizing or not accounting for their different vulnerabilities or needs. We heard stories of survivors receiving life-saving services. We heard stories of staff going above and beyond to support women, and survivors being so positively impacted by VAW services, they've begun volunteering. Our research illustrates that VAW services are essential, and the detrimental impacts of not funding or prioritizing the VAW sector and social care systems more broadly. As one survivor participant described, the women in the group are so amazing, and it's unbelievable that there was so much sadness and so much distraught in our world, and we're the ones who have to pick up the pieces. Like, we're not the ones who caused the trouble, but we are the ones who have to deal with the aftermath of the problem. So it's really amazing to see and hear some of these women where they were and where they're going. No matter where I go in my life, I'm going to take back. I'm not a victim anymore.
So as part of our knowledge translation, we have begun co-developing initial recommendations with the VAW sector based on the results that Alexa has just shared. Some of the recommendations are funders, including all levels of government, should provide increased resources and flexible funding to support VAW organizational responses. Organizations should increase funding and collaborative support to ensure they are meeting the needs of women facing intersecting marginalization. There should be a policy priority to strengthen VAW referral pathways and intra and intersectoral collaboration. Government should deem and support VAW services as essential services in public health emergencies, and VAW services and health systems should collaborate to implement and evaluate best practices related to delivering trauma-informed VAW services during public health emergencies that are grounded in anti-racism and anti-oppression principles. We want to thank everybody for joining us and taking some time to share in our results.
Hi, everyone. I'm Lisa Boucher. I'm co-leading this evaluation with Zoe Dodd and Samantha Young. And we looked at outreach supports for people experiencing homelessness in Toronto encampments during COVID. And our other team members are listed here as well. So just for a bit of background quickly, the COVID-19 pandemic created additional challenges, of course, for people experiencing homelessness, including the risks in congregate living settings and critical resources that they needed being closed. And so many people shifted to staying in encampments, including in tents and other structures, under bridges, in parks. And so in response, new and existing outreach services adapted to provide different kinds of supports to meet people's needs.
So before we began the evaluation, we held a logic building session with key community representatives, and we aimed to understand what kinds of outreach supports, including shelter or housing, were being offered to encampment residents, and how did these supports meet their needs and affect their lives. We used mixed methods evaluation with multi-stakeholders and a community-based approach. We conducted 127 surveys and 23 interviews with people who stayed in an encampment. We conducted 16 interviews with outreach workers and volunteers and staff from 6 groups or organizations. We recruited residents at 6 encampments between March and June 2021, and we analyzed surveys descriptively and used and interviews using thematic analysis. And what we're presenting to you today is the residents evaluation so far. Our full report will be coming out in December.
And so just to highlight that we had a lot of diversity. This is the survey sample of encampment residents. I won't go through it all, but we'll just note that 25% identified as LGBTQ and 26% Indigenous, 16% Black, and 11% other racialized identities.
So 17% of people were already living in encampment before the pandemic, where others moved from many locations, from the street, from places they were renting, from families and friends. 50% of people moved to an encampment for reasons that were related to the pandemic, and residents identified over 30 different encampments that they had stayed in. Many had stayed in more than one, and people often moved across these different settings between shelters in the streets and encampments, and many residents described finding a really trusting community or family in the encampment, often supporting each other and working together on daily tasks and watching out for each other.
And so overall, 69% of residents agreed that the outreach supports met their basic needs. So you can see in the supports they mentioned that they needed and received, this aligns with that: food, drinks, tents, sleeping bags. However, the supports that they most needed and did not receive, by far housing was the most common response. Some other important ones included phones, mental health support, and hygiene facilities.
Encampment residents also valued several key characteristics of community-based and volunteer outreach. Consistency and frequency was really important to people. Flexibility and responsiveness to their input. So people, if they asked for a sleeping bag, if outreach workers could actually get them a sleeping bag, so their input was necessary. And then help meet their social needs. So, outreach workers were checking in on people, texting with them. If something came up around a legal or healthcare issue, that was so important to the encampment residents that they had that support. However, encampment residents did not appreciate some outreach approaches which they perceived as uncaring or judgmental, such as if it felt more like security when workers were recording what they were doing or telling them what to do. So people talked about workers filming them, filming where they were living in their tents and their structures, and people did not like that.
And then just turning to the shelter and housing experiences. So yeah, people's interactions with city workers were often related also to getting shelter offers, and Many people experience those as being rushed or coercive by threat of eviction. And those who had been evicted, 32% went to stay in another encampment right after. And we will note that this is before the mass evictions in the summer. Also, overall, 55% of residents were ever offered a shelter option by city staff, with most of those being in shelter hotels, but only 4% were offered permanent housing. And among those who accepted those offers, 75% actually returned to live in an encampment again. And the most common reason for leaving the shelter housing offer was being kicked out, although there were many other reasons, including why people didn't accept those as well, including like violence, the rigid restrictions, and it being far away from their usual community.
And so many residents also reported not being very worried about COVID-19. Residents perceived that their COVID-19 risk to be lower in encampments compared to indoor shelter settings. They felt the air quality was better being outside, and this was the public health messaging that people were receiving. 80% had been tested for COVID-19 and 13% of people tested positive. And most residents were taking precautions trying to prevent COVID by social distancing, washing their hands or using hand sanitizer, wearing masks, and the supplies from outreach help people to take those precautions.
And of course, the overdose crisis was also a big part of people's lives, with most people having either experienced or witnessed an overdose in an encampment. However, residents said that overdose death was less likely in encampments versus in shelters and shelter hotels, especially because they were more able to watch out for each other and they didn't have issues with the staff.
So a few key points is that we need to provide affordable permanent housing. Community-based services should be supported in their outreach activities to hand out survival supplies and basic needs, be responsive and flexible, and that encampment residents should be listened to in decisions about encampments, shelter, and housing.
Great, and we just want to thank our community partners and especially the participants, and just honor those who are no longer with us.
Thank you.
This presentation highlights key findings and recommendations from the COVID-19 isolation and recovery sites evaluation. Here you can see a list of all of the members of our evaluation team. COVID-19 isolation and recovery sites, or CIRS, were established to provide a space where people experiencing homelessness who had tested positive for COVID-19, had been exposed to someone who tested positive, or had been tested and were awaiting their results, could isolate. We were interested in looking at why the CIRS models happened in the way that they did. What were the defining characteristics of the CIRS in terms of structures, services, and decision-making? Who was involved and what were their roles? And how did the model influence staff and client experiences? Here is a timeline of when the 3 CIRS sites opened, the partners who were involved, and how long the site was in operation. You can see that the Scarborough site was the first to open in March 2020, and that the Etobicoke site opened in April 2020 and is the only site still open. You can also see some photographs of staff at the sites.
Thank you, Michelle. The next set of slides will provide an overview of our 7 recommendations. Partnerships and models. Partnerships need to be inclusive and transparent with clearly defined roles for each partner. Decision-making structures need to be collaborative, innovative, and flexible. Partnerships and models as well should have pieces in place that address power imbalances. This could include written agreements, attention to how partners control budgets, processes that encourage ongoing reflection, correction, and open communication. And models should move away from siloed biomedical approaches towards integrated models. This next slide has a quote that speaks to the recommendations I just spoke of. And we have some pictures of staff working at one of the sites. Clinical status has a lot of weight in society, and I think people are used to their power and their privilege. And it's hard for them to relinquish it or appreciate that others have expertise that's more grounded in experience or community work, that sort of thing. So those were the big contested battlegrounds around addressing power differentials. Operations lead.
Thank you, Lori. Leadership. Leadership needs to have a collaborative decision-making and open communication. Opportunities for workers to voice their concerns, as well as accountability structures established early in the implementation of integrated care models. And the need to avoid structures which require multiple levels of approval, such as from both managers and executives. For peers, it was more on an emotional level, like more of a heart-to-heart, where some clients really feel as open telling nurses or doctors about, something that they're struggling with. Might it be they want a kit and they don't feel comfortable letting doctors or nurses know that? Hey, I need a kit for their substance. They'll usually come to peers or harm reduction workers and just say, hey, can I grab a kit? We'll bring it up. Or more of, I guess, they feel no judgment, kind of, because majority of them know peer support. That was from a peer harm reduction worker. Peer workers or people with recent or living experience should be involved in a wide range of health and social care settings. Expertise should be recognized and valued by people in leadership positions. Representatives should be included at all levels of decision-making, including the most senior. Positions should have stable funding, and workplaces should support workers.
Thanks, Lisa. Next steps and future models. Community groups, health groups, and governments should come together to develop and evaluate new models for shelter and housing support based on lessons from the SIRS. The models should incorporate a full set of coordinated multidisciplinary services for clients, include mechanisms for reporting regularly on their outcomes, accountability mechanisms for all partners, and flexibility in programming and funding. In particular, funders should prioritize resources for workers who interact directly with clients. These models are most likely to be successful if they have strong champions inside and outside of government, backed by a broad coalition of organizations committed to social justice. We found that the SIRS were an essential component of the response to the COVID-19 pandemic in Toronto for people experiencing homelessness. SIRS can serve as a case study for greater integration of services across partner organizations. The success of an integrated model will require careful attention to power imbalances in the hierarchies, which is critical for allowing all partner organizations to participate fully in decision-making. Addressing such power imbalances requires both formal agreements and processes, as well as establishing collaborative cultures. There was a strong consensus among participants that the lessons from the SIRS offer an important opportunity to rethink shelter settings. Such change will require a strong vision of what the alternative might look like, as well as sufficient funding, political will, and accountability amongst all stakeholders. The alternative, however, is to return to a system widely recognized to be siloed, inefficient, and not working well for clients. We would like to thank all of our funders, as well as the people who generously shared their thoughts, experiences, and time with the project team. We would also like to thank all of the workers who allowed us to use their photographs today.
Hello, my name is Jillian Kola, and I'm here today on behalf of my fellow co-leads, Kate Heyman, Gab Lawrence, and Alex Cottarella, and our entire research team to tell you a little bit about the findings from our evaluation of the substance use services at the COVID isolation and recovery site here in Toronto. Now, just to tell you a little bit more about the substance use services, you've heard about the recovery sites and how they were set up early in the pandemic to provide a space for isolation for folks experiencing homelessness in Toronto. And due to the convergence of the COVID pandemic, as well as the overdose crisis, there was a really strong feeling that there needed to be robust substance use services on site and available for clients. And this is what I'm going to speak to you about today. As part of our evaluation, we did 25 qualitative interviews with clients who were staying at the COVID isolation and recovery site, as well as speaking with staff from the site from the 5 different staff teams. Now, just to tell you a bit more about the services that were available, this included very robust harm reduction distribution of sterile injection equipment, as well as safer smoking supplies, the provision of cigarettes in an outdoor smoking space, a managed alcohol program for people who required alcohol in order to complete their isolation periods, as well as more clinical aspects such as the prescription of opioids, including opioid agonist treatments like methadone, as well as safer opioid supply, and stimulants as an alternative to the unregulated drug supply. People were also offered medications to treat withdrawal from alcohol or drugs if that was necessary. And there was very comprehensive overdose prevention and response services that were available on site, including an overdose prevention site and in-room witnessing from staff. Naloxone was also available to both staff and clients. And I think a very important part of the care that was offered around substance use at the site was the team approach and the interdisciplinary team approach, including from a team of people with lived experience, or the peer team, the harm reduction team, the nursing team, primary care providers who were available, as well as a substance use specialist team that was available for consultation when necessary. Now, just to give you a bit of information about the findings from the client interviews, clients overwhelmingly felt like the access to comprehensive substance use services was very helpful for them in completing their isolation on site, in keeping them safe and allowing them to stay on site for the period that was necessary. This included prescriptions of both opioid agonist treatments like methadone, as you can see in the first quote, where the client was talking about how they were able to have a continuation of their methadone prescription happen right away, but also safer opioid supply was available on site. And as this person highlights, it was necessary as they were taking fentanyl on top of their methadone, and the Dilaudid that they got as safer opioid supply really helped them make up for the fentanyl. And they said, I think the treatment here has been amazing. Clients also shared that they felt very much safer in the COVID isolation and recovery site than in other shelter settings due to the comprehensive nature of the substance use services that were available. And here the second client is talking about how they felt 100% safer, even with the check-ins that were way less invasive. They make them more welcoming. And here, this is really a testament to the work of the peer team on site, who had the majority of client contacts and really did a huge amount of the client care and interaction with people during their isolation periods. Now, in terms of findings from the staff interviews, staff overwhelmingly spoke about how there was an ability to say yes to client requests on site that was very much unparalleled in their experience working in other settings in the community or in hospital. People really felt they were working with a group of committed professionals and that they were able to really put the clients first at the COVID isolation recovery site. They also highlighted, however, that it was a high stress environment. And here, this is part of the nature of the pandemic response and the fact that they were responding to the COVID pandemic. The different waves brought different numbers of people at different points in time, which increased the stress level. But additionally, people spoke about how there was a lot of collaboration between the different on-site interdisciplinary teams, and there was a lot of training and rapid learning around harm reduction to really bring everybody up to speed to provide comprehensive services. It's important to emphasize here that the model of care was interdisciplinary and provided comprehensive integrated services that aimed to be a non-medicalized model where nonetheless people were receiving medical services as well as pharmaceutical prescriptions. And this is, I think, was highlighted as something that was very unique to the site and was a very good model of care that could be replicated in other sheltering settings. Now, one of the major issues identified was around discharge, and this was characterized as discontinuity of care in many ways because people were being discharged back to the shelter settings, which lacked comprehensive substance use services, which was felt to be very problematic by many staff and clients. And there was also issues around continuing prescriptions and interventions that had began on site, namely around safer opioid supply and managed alcohol programs due to the very limited nature of those programs in the community and the lack of capacity these programs had to take on new clients. So there was a very big difficulty with referrals. And here this client is talking about how they really felt like they'd stabilized on safer supply while they were at the site. And now they're going to be going back to using fentanyl on the street because of this lack of continuity of care. In terms of our recommendations, we have several recommendations for the broader health and sheltering system, including how to deliver a full range of substance use services for people who are living in sheltering settings, and that really this interdisciplinary approach, this comprehensive approach was both feasible and acceptable, and that there was a strong necessity for harm reduction and overdose response training across all staff teams in order to be able to respond when necessary. There was also a very strong feeling that harm reduction workers and people with lived experience of substance use were essential and necessary resources as part of the interdisciplinary teams and as part of the care being provided. And I just want to highlight as well that there is a strong need for stable funding for the delivery of comprehensive substance use services, as well as strong investment in long-term housing, affordable housing solutions, which was really highlighted by people in our study as a major issue going forward. And I would very much like to thank the people who participated in our study and who shared their thoughts and experiences with us, including clients from the site as well as staff members. Thank you very much.
Good evening, everyone. My name is Barry Isaacs. I'm here with Lynn Holness and Uzma Ahmed. We're going to be talking about the Sector Pandemic Planning Initiative Evaluation, or SPPI evaluation. On screen, you'll see our co-authors as well as individuals we'd like to acknowledge who helped us with this project. The COVID-19 pandemic has had a large effect on people living with developmental disabilities. People with developmental disabilities are diagnosed more often with COVID. They're hospitalized more often when they get COVID. They have higher death rates. They've also experienced major disruptions in services compared to adults who do not have developmental disabilities. The Sector Pandemic Planning Initiative was established in March 2020 by the developmental services sector in Toronto as a response to the pandemic. 28 developmental service agencies operating in Toronto, as well as legal and policy experts, make up the SPPI. The purpose of the SPPI is to address safety, labor, policy, training needs, legal and ethical issues arising from the pandemic. The resources developed are intended to be used to support agency management staff and adults with developmental disabilities through the pandemic. So what did we do? We evaluated the SPPI over three broad research questions. How was the developmental services sector impacted by the pandemic? Was the SPPI helpful? And how was it helpful in responding to the pandemic? How are marginalized staff and clients affected? We used a mixed methods research approach. We had an online survey to which 35 management and 53 frontline staff responded, and we did qualitative interviews with 24 staff ranging from frontline to executive directors in 5 agencies.
So what are some of the high-level results from this survey? First of all, 63% of the respondents noted that they worked in agencies where an outbreak had occurred. 80% reported that they worked in agencies where staff had taken a leave of absence or actually left their job. And over 3/4 of management reported that the SPPI was helpful or very helpful in helping them manage the pandemic. There was a question about pandemic preparedness, and these are the reporting percentages of those who rated pandemic preparedness as very good. So pre-pandemic, 14% of management and 23% of staff reported it as very good, whereas by wave 3, 80% of management and 70% of staff rated preparedness as very good. And just to drill down a little bit more, this is the reporting of the use of personal protective equipment. So gloves were used 28% of the time pre-pandemic. That increased to 42% during the pandemic. There was a substantial increase in the reporting of use of masks from 9% to 76%. And for face shields and goggles, pre-pandemic, only 2% reported using them, whereas during the pandemic, 36% and 25% respectively reported use.
So our qualitative interviews highlighted operational changes and impacts. So residential programs continued with major operational changes, and day programs initially shut down and then switched to virtual programming. Staff expressed that clients were impacted with respect to their routines, their employment, social activities, and their access to services. Some clients found it difficult to follow guidelines and to switch to the virtual programming. Some also experienced isolation, behavioral issues, fear, anxiety, and depression. Staff also experienced substantial work disruptions, for example, due to the single employer order, which meant that staff couldn't work at multiple agencies at the same time. They had longer hours, change in duties, and were adjusting to virtual work and experiencing burnout and anxiety. So many staff described the SPPI resources as helpful, time-saving, and trustworthy. So these specific resources that were identified were social stories, reopening documents, single employer guidelines, and webinars. They reported that these resources contributed to agency policy development, such as related to PPE, IPAC, and vaccine rollout. And lastly, staff shared that there was value in belonging to a network of agencies that were experiencing other similar situations. So our interviews also explored the experiences of marginalization. Staff discussed how the pandemic amplified pre-existing experiences of marginalization. So clients experienced greater isolation and stigma, and staff experienced an increased risk of infection, being in a low-paying job, and also the intersections of belonging to vulnerable groups. Agencies responded by establishing mental health and wellness initiatives, wage enhancements, and anti-racism training and committees.
So in summary, the pandemic resulted in major disruptions to services and challenges for agencies. Clients and staff were negatively impacted, and the SPPI was helpful to agencies in a variety of ways to respond to the challenges. There were pre-existing inequities and marginalization being experienced by clients and staff that were amplified by the pandemic. We recommend that other sectors working with communities who experience marginalization consider a similar approach as the SPPI for emergency preparedness, as it seems to be an effective approach. Also, public health and government need to recognize inequities and marginalized populations and factor these into pandemic preparedness and response. Thank you very much.
Thank you everyone for listening to the presentations. So now we're going to be moving forward to the Q&A. And so for our first Q&A, it's going to be addressed to the VAW team. Let me just pull them up real quick. Okay, so my apologies. So the first question will be, are you planning on taking these findings to the government?
So thank you for the question. As part of our knowledge translation, I think we plan on sharing our findings widely, and that would include different representatives from various levels of government. And I guess in terms of that engagement currently, we also currently engage with various representatives from different levels of government. And so I think that the findings will go wide, and we're very excited to see how it's mobilized and put into action.
Thank you. And the second question is, did VAW program participants share their preferences for service changes to continue or revert back after the pandemic? And was there interest in permanently offering virtual programming?
Yeah, so there definitely was overwhelming interest in a hybrid model of both virtual and in-person services. So both staff and survivors noted benefits of virtual services, including that they were able to access or deliver a wider range of programming to people regardless of where they were located. People felt in some cases more comfortable accessing virtual services where they could feel more anonymous than in-person services. But there were also a lot of drawbacks. So for instance, people experiencing housing precarity or economic precarity had a harder time accessing virtual services. Some women living with disabilities described challenges accessing virtual services, including feeling like their differences were on display for everyone to judge, and that made it harder for them to engage in programming. So definitely having a combination of virtual and in-person is beneficial to the VAW sector, but there also needs to be more funding going into supporting tech and infrastructure in terms of both equipment and training.
Thank you very much, Alexa. And sorry, and now I have 2 questions for the substance use services. So the first question is, how can all shelters adopt this client-first approach or YES approach?
Thanks so much. So I'll start answering, and then my other co-leads can also chime in. I know that one of the things that was really mentioned by staff was that the level of services that were available to be offered at the recovery site when it came to substance use services was fairly unprecedented in terms of the funding supports that were offered. And this really allowed for a peer team and a harm reduction team alongside the more medicalized teams to be properly funded and resourced in order to be able to respond so quickly and so appropriately to client needs. And so I think that that was really a key factor in this, is that the pandemic response allowed for resources to flow to the recovery site in ways that we don't normally prioritize sheltering settings and meeting people's very, very full needs within sheltering settings.
And the second question was, how were people with lived experience integrated into the study?
I'll start again, unless Kate, you want to take that part. We were very, very fortunate with the Marco study in that the research team dedicated significant resources to ensuring that we could employ people with lived experience as part of our research team as research assistants. And so over half of all of our data collection was conducted by people with lived experience. They were also very, very integrated in terms of our analysis team. And so we were able to ensure that they were part of the team that analyzed all of our study results and that helped with the writing up of the report, which I think was very unique and allowed us to really bring that lens to the data, and that was produced very, very fulsome findings that reflected the entire spectrum of experiences from the site.
Thank you so much for that comprehensive answer. And so the next question will be directed to the COVID isolation and recovery sites. What are the lessons you learned for post-pandemic planning? Did someone want to take the lead in answering?
Yeah, I can probably take the lead in answering that.
Thank you, Ahmed.
So I think there was a lot of discussion and a lot of interest amongst all of our participants about how to move forward to rethink how services are offered to people who are experiencing homelessness and what the COVID isolation recovery sites could to do to inform those. So a lot of interest in integration across the different partners, bringing partners together, really building structures that allow partners to work together effectively, have open communication, to break down some barriers related to power imbalances, but also a lot of acknowledgement, recognition that to move forward will require infusion of new resources, and that will require strong champions, both within government, but also advocates and activists in the community to keep pushing that forward as well. I don't know if Michelle or Laura, you want to add anything?
And the next question is addressed to the encampment study. So all of the evaluations were done in Toronto. What lessons can be learned for other cities?
Do you want me to take it, Lisa?
Either way.
Okay, you go, Lisa. Well, I'll tag on.
My video is changing. Yeah, just to say that, I mean, we've already been contacted by a few other cities actually from another presentation. So there's, with the pandemic, there's been encampments pop up. People might have heard around in many different places. I'm Hamilton, Victoria, Vancouver, Ottawa, Edmonton, Halifax. I think sort of most provinces actually that there's been some, obviously more in Toronto. And so, yeah, we think that there may be some important lessons. Not sure exactly what yet. I think we'll need to explore that with some of these other cities in discussion. So I think that that's something that we are planning to look at for future work.
Yeah, I definitely think that there's definitely lessons learned, especially around the inaffordability of housing and also listening to people who are homeless. And that's what we heard over and over again from people we interviewed, people we talked to, both workers and residents, is that people need to listen to them and listen to the people who are experiencing homelessness. And I think that's a lesson that can be learned across other cities, and also like evaluating what it is that you're doing, evaluating the kinds of supports, or thinking about in terms of collaboration. I think one thing we heard a lot was there was a lack of coordination. There wasn't there wasn't emergency preparedness for the almost 1,000 people outside. So these are all lessons that could be learned from other cities for sure, and towns.
Thank you so much, Zoe. And the next question is going to be directed to the Sector Pandemic Planning Initiative team. In some residential settings, the one employer rule led to more full-time hours and better compensation. Were benefits of one employer rules identified?
Okay, I can start with that one. I would say that the pay enhancements and ideas of working longer hours were definitely came out of the interviews. I wouldn't say they were exactly connected to the one employer rule in terms of a benefit, but they were discussed. And there were other benefits of the one employer rule that were also discussed, like really the necessity of it and the importance of it for infection prevention and control and whatnot. I don't know if you have, Chelsea, you may have something to add to that.
I think often when people talked in the interviews about the one employer rule, they were talking about often like staffing needs or staffing issues. They were finding that a lot of people ended up leaving to go to other jobs that were that they had that were giving them more hours or better pay. And so they were deciding to go elsewhere. So that's, I think, where a lot of people were discussing the one employer rule.
Thank you so much, Chelsea. I do have another question for the COVID isolation and recovery sites. How did you incorporate intersectionality into your analysis?
I can start with that one. So we definitely asked all of our participants how the CSRS services and supports met the needs of clients who self-identified as Indigenous or who were racialized. So we definitely have looked at data, but again, we were speaking mostly to staff, administrators, managers, and leads. So we don't have the perspectives of clients in this particular evaluation, but we were able to look at how the CSRS operated within the system more broadly. And we did hear a lot of people speak about larger system issues with respect to housing, with respect to the overdose crisis, and how the CSRS were meeting the needs of individuals experiencing homelessness within those larger systems. And so some of our analysis really focused on, well, what have we learned from the CSRS and what could we say about next steps in terms of meeting those needs? And how can we break down some of the silos in terms of robust funding and infrastructure models that are integrated and that actually facilitate partnerships that are meaningful and where people have equal decision making.
Thank you so much, Michelle. And this is going to be directed to the substance use services team. So did you work with hospitals specializing in substance abuse and addictions change? So for example, like distributing like methadone, et cetera.
Sure, I can start on that one. So the COVID Isolation and Recovery Site operated in partnership with University Health Network for the first year of the pandemic. And so the pharmacy and clinical practice leads were helpful in getting some of that policy in place around safe storage, for example, of medications, which were delivered from the pharmacy that already had an existing contract with the city. A lot of the reflection from interviews with providers is that what was really helpful to get the substance use prescribing going was twofold. The first was having access to substance use consultants who were prescribers from across the city, many of them concentrated at downtown hospitals for the rest of their clinical practice, where they have a lot of experience in addictions. And also the creation of a substance use manual, which was used by the primary care providers to initiate treatment at any time. So those two tools, access to the consultation service and the availability of a manual, really helped to ensure more seamless prescription for people who needed OAT or hydromorphone.
Thank you so much, Kate. And this last question will be directed to the encampments team. Should mobile phones be considered an essential service also, as identified by the residents?
Yeah, so mobile phones were something that the residents said that they needed. It was something that they definitely could use. I mean, there was residents who told us how outreach workers, especially the encampment support network, would call and check in on people and be able to text them to make sure everything was okay. And also if they needed something, so if someone just showed up in the encampment and someone needed a tent, they could like text a worker to come and bring them a tent. Or if there was some sort of legal problem or the police or the city showing up to clear, they were able to communicate with the outreach workers, and the outreach workers were able to communicate back. I also think people talked a lot about things being closed down, not being able to go anywhere because of fear of losing their things and being in the parks. So having a phone was a real necessity for people, especially when things went virtual, and also for people to be able to get in contact with like healthcare providers and others. So yeah, phones became an essential, definitely an essential tool. I mean, so much stuff went virtual and people talked a lot about the need for a phone. Yeah, right up there with a tent and sleeping bags. So. And food.
Thank you so much, Zoe. I believe that's all the questions for this evening. If you have any more questions, please feel free to email Marco at unityhealth.to if you have any more questions or anything regarding like the webinar that we're hosting tonight. And with that, here's our conclusion. So I want to put forth and thank everyone for attending our town hall. Myself, along with the entire Marco team present today, are very grateful for your presence and your participation. So again, thank you everyone for listening, and I hope everyone has a pleasant evening.
Thank you.
Thank you, everyone. Take care.